Okay, so today's chapter we're gonna discuss healthcare records. Everything is about medical records. Most of the information that we're gonna discuss here, a lot of stuff overlaps everything that we have covered. Remember that is the way that these courses are taught because we want you to remember most of the things. So one chapter have we add different topics, but still we go back to most of those topics that we covered before. But because we have to mention it because it's part of it. That is what medical records is all about. So we're going to be talking about little things that we talked before, not in so much detail, and we're gonna address new topics as well. So we put it together so we can understand what's really going on. This is like a puzzle. We have these pieces, we have the whole picture, but then kind of break it down again and put it together. So to make sure that you get this information. So there are two terms that are very, very important to understand. In this case, we talk about paper-based medical records. That is one thing. Now we are talking about the digital part, the electronic part. But then when we talk about the electronic part, there are two uh, topics that sounds like the same, but actually they are not. So it's very important. When we say paper-based medical records, we know that they are made on paper. That's it. This is how we keep the information on paper. Now we're gonna be keeping the information in the computer. Let's put it that way. But now we're gonna have information that are gonna be used only for this particular institution, the medical office, versus information that we can share with other providers outside of our office. So that's basically what it is. So we're gonna introduce different topics. Also, we're gonna introduce not only um, the patient's medical record, but also, the portal for the patients to access the medical record. Remember, patient's health record is one thing, medical records is another thing. So that's basically what I want you to remember. Because these terms, these names, so to speak, they are kind of a little confusing sometimes. So when we said patient's health records, we are talking about the patient's a personal access to the medical records. So that's basically what it is. Versus the patient's medical records. So we're going to be talking about these personal medical records, which belongs to the patient, not the medical records that we keep in our office. That will be medical records, whether they are electronic medical records, whether they are electronic health records. So the same happens to the personal access of the patients at the medical records. So see, it's a little confusing. I understand it because I deal with that. But just think about there are medical records, which is the ones that keep the medical personnel keeps the records for the patient, keeps all the data for the patients that have been collected from them, whatever it is, treatments, whatever it is, conditions, procedures, medications, labs, any other tests that have been ordered. That will be in the hands of the medical providers. Here we're going to talk about the medical records, but the one that the patient have access to it, whether in the computer or in the office. When they come, they can access the medical records, or they can access it from home, from their own computer. That's basically what we're talking about. So I don't know if any one of you have an account with your doctor or with the hospital, and you can see certain information about your history, exams, and things like that, medications, because that's what's called the patient's portal. That's what I actually know it as, because patient's health record and patient's electronic record, it gets a little confusing. It's just the patient portal where they have access to it. So most of the clinics, most of the medical doctors and hospitals, outpatients particularly, they give access to the patients to enter information, to make appointments through their portal, so they don't have to come to the office to do it. We just have to approve them. We just have to read that information and then send the patients a confirmation that we have the appointment, confirmation that they entered some personal information that have happened to them, or any complaints. We're going to receive it, we're going to review it, and then we're going to answer to the patient. So that's basically what these terms are all about. Now, this can happen again, whether you are in the emergency, whether you have an acute condition, or you're just a regular patient in a doctor's or outpatient's office. That's basically what it is. So for this type of information that we're going to enter on the patient's medical record, again, it might be medical record because only this office has it, and you can have access to it through the portal. The other one, but then if we don't have, you cannot send this information to someone else. So that is the difference between health records and patient medical record. Let me make it even more clear, because this is a little, it has right here, patient's health record. Now it said has replaced patient medical record. So medical records are this information that we have in paper. So that's basically what it is. Patient medical record, you go over there, see if you want a copy, they give you a copy. Yeah, that's it, it's paper. Now, patient's health record, now is different. This is the patient's portal. Now you can get access online. You can, from, from your home, from your computer, wherever you are, from work, you can just log into your account and you can check what's going on with your medical stuff. That's basically what it is. Because we have electronic medical records, electronic health records, but those are the ones that belongs to the organization. That will be discussed on the next chapter. So that's basically what it is. So patient medical records, oh, well, the patient comes into our office, we have paper, so we need to pull that record if the patient needs copies, if the patient needs some information from there. After the medical doctor gave us the authorization, we can release some of the information. Now, on the other hand, patients have records. The patient don't need to come to the office. They can access some of the information online. They open their own account, they have access to certain information from the medical care, and that is it. So that's basically what it's trying to tell you here, nothing else, just to make it simple. Nothing to do with the medical records, electronic or health records, because those are the one that keeps the medical office. These are the ones that the patient have access to it. So of course, we need to replace patient's medical record because the patient cannot access that information whenever they feel like it. They have to ask, they have to give they have to sign a consent or release some information. Whereas if you do it online, now there is certain information that you just log in and you can see it. You just have to make sure that not every single part of the information from the patient is going to be there. It's only certain information that the patient can see. The patient can copy it, the patient can send it to their medical doctors or whoever else they want to go see, said, hey, I'm getting this, but we only give you access to certain information. So that's basically what it is. So I want you to understand, because later on the next chapter, we're going to be talking about electronic medical records and electronic health records, not patient's health record, not patient's medical record. So that will be the portal for the patients, access to the patient's information. We will discuss as we move along. So data or data, remember, you can pronounce it data, you can pronounce it data. I'm used to use data most of the time, so I just stick with it. Data means both computer information and information in the health record. In other words, it means information that we can share electronically and the information that it is in the paper-based medical record. Any information that we collect from the patient, from the exams, from the tests, from laboratory, from other physicians, are going to be collected in the patient records. That's basic. That can be done in different formats. We know that paper or electronic. So it is just the data. The data is the information. All the information that we collect in places, whether in paper or electronically, that's called data. So those are terms that is important to understand, because we're going to be talking about this. Here we're going to go back again and talk about the functions of the healthcare record. Remember, now we're talking about whatever we have in our medical office, not what the patient has, because the patient's portal or the patient's personal records, those are a little different. Remember, all the information is not going to be found over there. We are going to give the patient access to certain information from their medical records. So we're not going to see everything. We're going to see only what we're going to see on those personal health records. We're going to see what the patient's information, because it belongs to you. We're going to see medication that the patient is taking, diagnosis, conditions that the patient is being diagnosed with, some of the procedures, lab results, but only those lab results that have been already discussed with the patient. Any new results, any new tests, any new procedures that we planning to order or we have not discussed with you will not be placed over there. You're not going to be seeing all the correspondence, not all the appointments, things like that. When you enter to see the appointments, you're going to be seeing the date that you're going to make the appointment, not going to see all the appointments that you previously had, whether you have cancellations, whether you didn't show up. None of those things are going to be there. So certain things are not going to be there for you. If I refer you to another physician for this and that you will not be able to see it. You're only going to see what was the procedure, what was the test, what was the results, if it was discussed with you, and what medication you're taking, the diagnosis that the conditions that you have, and that is it. That's basically what you're going to have. Everything else that belongs to the medical facility. So that's basically how it works. So what will be the functions of the health record? Serve as a principal communication. Again, we are going to document everything about our patient. Everything, whatever happens, whatever encounter that we have with our patient in the office has to be documented about signs, symptoms, medications, diagnosis, procedures, any plan that we have done to treat you, whatever happens, referrals, all that stuff is going to be here. Remember the correspondence, letters that we send to the patient, letters that the insurance sends to the patient, and so on and so forth. So all the things related to the insurance payments to us, you're not going to be seeing it. So all that information belongs to the medical doctor. So that's basically what it is. We have all the information from all encounters that we have with the patient. We have all the paperwork about diagnosis, all the paperwork about what we charge for the services, whether we will pay or whether we not pay, anything that, comes from you and from the people that is assisting you or getting involved with your treatment, we're going to have all that information. So another thing that is very important that I mention all the time is these medical records, whether computerized, whether paper-based, they are legal documents. They are legal. They are the ones that if anything with the patient, if the patient complains, if the patient sued the office or the family sued the office because of the patient's, outcomes in medical issues, we're going to have to present the medical records. So for that reason, the medical records needs to be kept complete, accurate. So we need to have all the information from the patient that we have collected, and every single encounter, we have to have it documented. Every single lab test result, we need to have it right there. Any referral, we have to do it right there. Any consultation with an independent medical doctor and other specialists that we refer our patient, we have to have that information. Any medication that the patient is taking, any medication that been discontinued, medication that have been added on to the patient, everything we have to have it. So that is the importance about the medical records. And we know that we discussed this just using different terms, so kind of add a little bit to what is contained within the medical records. Now, functions. So what we kept in the medical records is all the information that we collect from the patient, whatever the doctor does. But what is the purpose of the medical records? Provide basics for improvement in the healthcare delivery. Remember, if I know what is it that what your complaints are, what your symptoms are, what are the signs that I discovered after I ordered those tests, after I did the physical evaluation, after I consult with other professionals, well, we're going to have that information there. So we're going to know how to treat you. So that's basically what it is. Now, this information is not just for us, the medical providers, remember, and the patient. This information is also good for other organizations that are participants, that are associated within the medical care from the patient. That's basically what it is, because we have to be abide by all these organizations that, accredited our organization. Keep an eye on our organization. So that's basically what it is. Remember that we have to report any medical conditions to the CDC, and the CDC is going to report it to the World Health Organization, which is WHO. Again, we have to have all the information collected from our patient, because that's for, security purpose. We are protecting the public. We don't want a condition that the patient have, particularly these infectious diseases, to be, spread all over. So we got to keep informed the entities that can help to prevent this and to protect us, and to the pharmaceutical companies so they can create medications. So Medicaid can manufacture medications that they can help and assist the patients in all these conditions. That's basically what it is. Now, remember, we can use this information for research. I already mentioned it. For the pharmaceutical companies, if they know that this condition is happening and is happening more often than expected, then immediately start thinking about, manufacturing medication to counteract this new medical condition. And other companies are going to be in charge of manufacturing or building these machines to evaluate, to test new machines, many things. So that's basically what it is. So if we don't keep the information from the patient, well, nobody's gonna know what's going on. So we're not gonna have the resources that we need to protect those patients that might be infected with these conditions. We're not gonna have the proper training for people that are gonna be dealing with these conditions. Remember, there is always one condition that appears that we didn't know about it. And that's why we have these coding manuals that we add every year. All these codes, all these new diagnoses, all these new medications, and also we remove those medications that no longer that were, removed from the FDA have removed those from the market. So we're gonna add and we're gonna remove as well. There is always something new, and that's why we have to keep all this material, all these manuals for billing and coding and diagnosis. We keep them up to date because things are changing completely. And the information from the medical records is the one that help us out to do that. If there is something else, see, before the COVID, we didn't have COVID, so we didn't have the diagnosis, we didn't have those vaccines, we didn't have this testing. So therefore, now it was added to it, new codes. Now we know how the condition presents, what are the signs, what are the symptoms, and we know how to treat it because we have the medication as well. So if someone now presents with this type of signs and symptoms and it turns out that you have the COVID-19, now they know how to treat it versus when we didn't know because it wasn't something that we had. Let's talk about primary and secondary records. So what is primary records? Primary records are all this information, all this data that has been collected directly from the medical providers and it is associates. That's basically what it is. Everything that comes directly from the sources, we are going to add it in your medical record. So all the information. So patient comes to our office, comes with a chief complaint, that is part of the primary records. Now the medical doctor is gonna do evaluation, it's gonna be sent for textings, it's gonna be sent for some imaging reports, some referrals, because we're gonna get to the bottom of the problem. All that is primary records. We're gonna bill the insurance is gonna pay this or not for these particular procedures. We're gonna add that to the medical records. So now we know how much the insurance paid us for the services. So everything is important, not just for the patient, but also for the benefit of financial purposes of the institution. So we're gonna have all this data right there that it was collected directly from different sources for the care of the patient. Now, that's primary records. What is secondary records? Oh, well, before we get there. Again, because these are the primary records, we're going to be using it for the patient care. Remember, and also for financial, that is going to benefit the institution. It will go back again as a legal document, just in case something happened, the office wants to protect themselves, or the medical doctor wants to protect themselves from a lawsuit. We have all the information that we have collected. And this is the primary records, the one that we send. So if we examine the patient in an outpatient's office and we do certain evaluations, certain testing, certain give the patient diagnosis, give treatment, all that's part of the primary diagnosis. If you go to the hospital, you go to the emergency, and you've been admitted to the hospital, all that counts as primary records. If you've been admitted to the hospital, the day that you release, you're going to have a discharge report. So that is part of the primary medical records. From the day that you started, from the day that you've been discharged, we're going to keep all that information, what was done to you when you were admitted, what you were admitted, and what was the outcome at the end when I discharged you. So all these reports. Now, if you are an inpatient, meaning you are admitted to the hospital, now we're going to have other notes that in an outpatients we don't have, which is the nursing notes. Remember, the nursing notes, we have it in patients that are inpatients, patients that have been admitted. Why? Because the nurse plays an important role. The nurses, they are the one who administer medications. In a regular basis, even though if there is a nurse in the doctor's office, usually doesn't have the same role as a nurse in an inpatient setting. Because the nurse is giving medication, is cleaning wounds, is changing dressings, is giving patients education, and doing a lot of stuff. So it will be included in the medical records. So that is part of the primary medical records. Remember all the orders from the doctor to the nurses to give a medications or to administer medications, test results from the laboratory, whether it's internal laboratory or external laboratory, or from the results from a referring physician or a specialty doctor, everything is going to come back to us and we're going to add it to the patient's medical record. We know already from the administrative part, that will be all the clinical aspects, but we have the administrative part, which is all the patient's information. And with the patient information, it is the financial part, which is when we have the insurance ID, which insurance or what insurance is, because patient might have more than one insurance, that information is also going to be there. So again, we have the patient's medical history, patient's family history, patient's social history, everything that we discussed before. It's just done. Again, as I mentioned before, we have to repeat all this so we can put all this together. Those will be the primary records. Now, what are the secondary records? Just to summarize so you can understand, the summary of the secondary records, it is part of the medical records. This is the information that we are going to remove from the medical records to give it to a specialist. If they're going to do a surgical procedure of this particular organ, this particular part of the body, we only going to give this medical doctor information pertaining to that. We're not going to release all the information. It's just little information. And this is not information that we are collecting. Because remember, primary is information that we collect from all the sources, all the people who intervenes with the treatment of the patient or the care of the patient. Secondary record doesn't work that way. This is for us to release what information from these primary records we are going to release to the patient, to another doctor, to a referring physician for a procedure. They don't need to have the whole information. They just need to have part of that information, part that includes what it is pertaining, what is related to what the patient is going to receive, what type of procedure, what type of medication. So that's basically what it is. And of course, that applies also for financial purposes. We don't send all the information contained in the patient's medical record to the insurance company. We don't do that. That will be violation of the patient's privacy and confidentiality. We don't do that. because this is one of our associates. They need to know certain things so we can get paid. We mentioned this before. So we're going to give only the information that they need for us to be reimbursed. For instance, we have to tell them what was the diagnosis, how services, for how long, what was the time frame that we spent to evaluate the patient. Those are services. Or procedures. Oh, we did this particular procedure. We did blood, we did the EKG. They did put some stitches, they put the cast, they did this minor surgical procedure or this major surgical procedure. All that has to be added there. But again, only what's important, very summarized information, the diagnosis from the procedure, the diagnosis from the medications that we ordering because they get paid for it. So that's basically what it is. Because if we don't give this, the information to the insurance and includes patients' personal protected information, then they're not gonna release the information. They need to know who was the patient, what services were provided to this patient. Now we're gonna decide how much we're gonna reimburse for those services. Remember that these insurance companies, they reimburse depending from their policies, their agreements that they have. They never pay 100%. Some of them pay 70%, some 80%, but it don't go beyond that. You have to be responsible for the balance. But then we have to send the correct codes so they can reimburse us for the procedures done. And not leave all the burden to the patient. Because otherwise the insurance company is gonna say, oh no, I don't have here the whole information from your medical doctor, so we're not gonna pay for those services. You are responsible to pay for it. So it's our job to send all the pertaining information from our office so we can get reimbursed. And then the balance will be paid by the patient. That usually depends on what insurance you have. What is the plan that you have? How much money you're paying for that insurance? What covers your insurance? So that's basically what it is. Depends how much money you pay for your insurance and what it covers your insurance. Then they tell you more likely how much you're going to be responsible for it. Remember that there are some procedures that are not covered by certain insurances, or the amount of the percentage of reimbursement is going to be different. All the insurances work differently. They are independent. The only one that works the same is the government insurance, because it's the government who is paying. Well, not the government, once again, the taxpayers, but it's through the government that they release the money. So those are like more standardized, but still varies from insurance to insurance. They have their changes. It's not that Health Plus is going to pay exactly the same for the services that pays Fidelis, that pays MetroPlus, and whatever other insurances are out there. But the point here is that we are going to release the necessary information to these organizations so we can get paid, particularly if we were talking about insurance. And if the patient is hospitalized, remember that we're going to send those claims. There is a billing department within every single institution, whether it's physically present within the organization or it is an independent contractor. It doesn't matter. But every single organization, whether funded by the government or is privately funded, they're going to have a financial department, because that's what moves business. Just because the organization is non-for-profit does not imply that, oh no, we're not charging, so we're not getting paid. So the people who work there has to get paid. The services from the building, the utilities has to be paid. The machines, the equipment, all the supplies, everything has to, where is the money coming from? So we get paid, people makes money. It's just that this money do not come from private sources. It comes from taxpayers that the government releases to these medical facilities. That's basically what it is. Now we're gonna have a list that is called the Master Patient Index. This is something that is usually used in insurance, because that's when we are going to have in the system all the names of the patients that we have. That's called the Master Patient Index. Think about all the contacts that you have on your phone. That is called your Contacts Master Index. So those things, we have it in our records. A patient that had been admitted for a certain period of time, we're gonna keep those records. Remember, all these counts, because we need to know for how long the patient was admitted, what condition the patient was admitted for, what was the outcome, for how long the patient remains hospitalized, 24 hours, 48, 72, 1 week, 2 weeks, 1 month, 6 months. It was transferred to another institution. We need to know everything, but this is information that is related only to the institution. And that information, we never release it to the patient. To the courts, yes, if there is a lawsuit. But when the patient have access to the information, we're not gonna release any of this. Oh, you enter this hospital for this period of time, stay this period of time, they pay us this much for this. No, they don't see that. They're gonna see that they have a diagnosis. They're gonna see that they were admitted for this diagnosis, but they're not gonna say that it was admitted. Oh, you have this diagnosis, and you're taking these medications for that particular condition, but it's not gonna relay information. That is called secondary. So we're gonna kind of summarize. We're gonna remove certain pieces of your information, patient's information, and we're gonna release only the information that is needed, that is pertaining to whatever we want the patient services to receive. So that is secondary. Remember, secondary, we have the information and we are going, because we have it, we have control of what type of information we're going to release and to who, with which purpose. Now that we're receiving the information, primary medical records is all the information that we gather, all the patients that we have in patients' records. Secondary is what we release, but we don't release all the information, only whatever is needed. Remember, whatever is necessary. That is secondary. One of the good things, so do not worry, I just want you to know, because remember, sometimes we think that because we own the information in the medical records, we are entitled to receive everything that contains the medical records. No, there is some information that you're not gonna receive. First of all, because it's not relevant to you 100%. So we need to know is what is your diagnosis, what is your conditions. You need to know that I send you letters, a collection. What do you need that for? Or they send us letter to request for something. You don't need that. But you need to know what medication you're taking, what procedure have been done to you, or to the institution that is going to do this procedure. So we're going to release just that information, not more. That is it. That's secondary records. Remember, let's look what we release versus what we take. What we take, what we collect is called primary records, and we collect a lot of information because we need it there. If we will report something to the CDC, all the medical conditions, or all these communicable diseases, we're gonna have it recorded right there, but that's not gonna go to your medical records. If you ask for a copy, we're not gonna give you that information. That's irrelevant to you. Even though if your condition is being released to the CDC, we're not gonna tell you, oh, well, by the way, we released that, you have diabetes to the CDC. No, doesn't pertain to you because first of all, we're not releasing your protected information. We just have statistics about how many people in this hospital is being diagnosed with diabetes in 1 day, 2 days, in 1 week, in 1 month, this hospital, this location, this town, this state. That's basically what we do. So there are a lot of information contained within the medical records that is not necessarily to release to anyone. Stays within the hospital or the person that creates this medical record. That's why when we talk about who owns the medical record is the person who created, the institution that created belongs to them. So they have the right to keep certain information because they created it. Only what pertains to the patient, it will be released. Remember, exception to the rule, if we have a court order, then it's a different issue. Other than that, the information is not, the medical records is not released with all the information. In that situation, we release everything because they need to know exactly what was going on. Demographic data. So this is other part. We talk about demographics in this part, this letter, this title or this statement, demographic data, is so important. Sometimes that medical doctor can ask you, can you get me the demographic from this patient? And then you say, demographic, what are they talking about? So what they want is the patient's personal information. They want to know who's the patient, what is the patient living, what is the contact numbers, what is the email, what's the phone number, what is the insurance. That's demographics. It has nothing to do with medical. I need to know who is my patient. Think about you when you say, oh, that is my personal profile. In your phone, you have your personal profile. In your any of these social media applications, we create a profile. Some people put a lot of information there. So that's basically what, that's demographics. Everything that we collect from the patient from the moment that the patient joins our office, but this is related to the patient. So the demographics is not something that we're going to ask someone else. No, that's your personal information. What is your name? What is your last name? What is your date of birth? What is your social security? Your driver license, your telephone number. Where do you live? What is your address? Do you have an email? What is your email? You have an insurance that's going to pay for your bills. Oh, I have an insurance. It's the only one. Do you have a second insurance or secondary insurance? Because remember, whatever one the main insurance, the primary insurance doesn't cover, the secondary insurance can cover it. So it's important. Otherwise, you're gonna pay from your pocket. So all the information from the patient, including an emergency contact. Remember, don't forget the emergency contact, because the emergency contact is someone that we are going to contact in case that we cannot reach the patient or something happened to the patient. We're going to inform this person because an emergency contact is someone that you gave us. It's a contact person that you gave us to inform certain things in case that we cannot reach you. Or for some reasons, you're not available, something else. So we're going to reach that person. So that is demographics. And it's here. So I mentioned before, I mentioned all this. Includes name, address, phone numbers, next of kin. Oh, if you're married, oh, social status. You're married, you're divorced, you're a widow, you are so many things. An emergency contact information, again, social health, social security number, medical insurance. There's a lot of stuff that we're going to collect from you. So that's how it works. So it says right here that it's called the face sheet and paper-based medical record. Well, do not worry about this because this never asked. So again, just know what is demographics. Demographics is all the patient's information. And if you've been asked, what's the first part of the medical record? What do you encounter in a medical record? What is the first thing that you encounter in the medical records? What is the first data? Demographics. Because we need to know who's the patient first, and then we start collecting anything else. Now, if it is, what is the first thing that you record for the patient on the sub note, or what is the reason that the patient came to look for care in our office? That's a different issue. That will be the chief complaint. So you have to make sure that that's what we go over and over these things to learn about the SOAP note, the SOAP, the subject, objective, assessment, and plan. Because the questions from here, the questions that you're gonna get are from here. But if you don't understand it, you just randomly gonna select the wrong answer. So the first information that you're gonna encounter on a medical record is gonna be patient's demographic. They're not gonna say the patient's information, the patient's profile. No, it is called demographics, not the chief complaint, not the present illness or the patient's medical history. No. First thing that we're going to encounter in medical record is the patient's information. That's the first page when we open the medical record. And from then on, we encounter everything else. So that will be like the first section, like first chapter. Think about, open your book from the school or whatever other book, and what are you going to encounter in the beginning besides the table of content? Well, who wrote the book? Who's this person? How many other books this person? What is the publisher? What is the edition of this book? Whether it's a bestseller or not. To whom this book is being written about it. So that is demographics. So don't forget demographics, because demographics are very important to know. Remember, these type of things are what they like to ask. And they're not gonna say, okay, what is demographics? That's not what they're gonna ask you. They're gonna ask you the first information that we encounter for the patient in the medical record. What is it? Oh, that's the patient's demographic. That's when we have all the information about how we identify the patient. And that's the information that we should not release, because that's the one that has the, the protected health information. It's about that, because it's where we have all the information from the patient. So when you open the medical record, the first thing that you see is the patient's name and all the patient's information. So we don't want that. That's what we protect that. If you're gonna open the medical records in the middle and you see the progress notes, oh, but it says the patient's name. Not good. You open a lab result, oh, it says the patient's name, it has demographics. Not good. Because we need to write down to whom this information belongs every single time we document something. Why? Because if we lose that page when it was paper, how do we know that this belongs to this patient? A page with medical information, but no name. Makes no sense, right? Think about your phone bill. You receive your phone bill, but doesn't have your name on it. the address, the number that you're paying for. Well, if it doesn't have this is the protected information. Not how much you have to pay for the service, what plan do you have. We don't care about that. We care about this protected information, protected health information. Again, so that's basically what it is. When this paper-based medical record transitioned to electronic, now this paper was scanned or using other electronic devices to convert them into electronic files. Because can you imagine a medical record start typing everything that is written there and start typing it, passing it into the computer? That's not going to be possible. That's not going to be possible. It's very difficult to read the doctor's handwriting. So it's not going to happen. What we do is we just convert those to electronic. It's like PDF format, PDF files. We're going to take a picture of those and we're going to put it right there on the electronic medical records. That's what has been done, because we don't want to see those shelves and that paper anymore. So we're going to convert those files that are paper into PDF formats, but digital forms. And we are going to create the medical record electronically. But you cannot make no corrections, no nothing. Remember, the PDF format is something that you cannot edit because those are not editable. So that's basically what it is. It's like a picture. You just put the picture right there. You're not going to be able to correct it. So it stays like that, because we need to add that information. So that will be the demographic data. Remember, all the patient's information, that is the demographic area. This is what's considered the protected health information, because we need to protect who this information that we collect with this diagnosis, these medications, treatments, who do they belong to? Because if I don't know who they belong to, no worries. No worries. See, if I found your ID, your passport, your driver license, I know immediately who to look for, because it has a name, it has an address. But if you just say, oh, this is a driver license, no picture, no address, no nothing, do we worry about that? No, we don't. There's no ID, no identifiable information. So for that reason, we don't care about that. But unfortunately, most of these documents contains these personal data or demographics, so we have to take care of it. As a legal document, these medical records, remember, they are legal if they are required by the court of law. That's the only time that, or it is request to release this information to someone else. That is legal, because we have to follow HIPAA regulations. We always require a consent, remember, and a form of release of information to disclose the patients. And here again, remember, PHI. Forget this. This is protected health information. Do not fall into the trap, because they're going to put personal health information. This is not personal health information. This is not provider's health information. This is not patient's health information. It's not. P stands for protected. Oh, but it belongs to the patient. Yes, but the P doesn't stand for patient, provider, or personal. It's protected health information, because they're going to ask you PHI. And then you're going to say, oh, personal health information. oh, patient health information, because it's the first thing that comes to our mind, because we relay everything like that. No, it doesn't mean that. It means protected health information, because all the information, all the demographics from our patient needs to be protected. So basically, that's how it is. Other legal papers that we use: consent for treatment. Remember, treatment can be certain medications, procedures. So if it needs consent, and it needs to be written consent or informed consent, we have to give it to the patient and keep these copies of this consent within the patient's medical record. The consent, the patient signed it, that the patient doesn't keep them. Remember, everything that we collect from our patients goes to the patient files. We need to keep them. If the patient says, oh, I want a copy of that, not a problem. I can give you a copy of this. Usually for procedures, if you give the consent, we don't give you a copy, but if that comes into the case, but remember, if the patient asks a medical assistant, a nurse, for a copy of any of the documents included within the patient's medical record, we do not release them. They have to sign a release of information to request that, or follow the policies of the organization. If it is blood results or something, results from a test, the medical doctor needs to authorize that. So don't think that because, oh, this is just a little paper, I can give the patient a copy, I'm not gonna go bother the medical doctor. No, because if these results have not been released to the patient, the medical doctor has not discussed this with the patient, or the medical doctor didn't review it and says, oh no, that's everything is okay. And it turns out that something was serious there, and you release them, and this patient takes these results to someone else, to another doctor, that can be reasons to sue the medical doctor. And we are at fault because we release that information. Remember, we should not release no information whatsoever without notifying the medical doctor. So it doesn't matter who they are. We always make the mistake with people that we know, neighbors, friends. Don't do it. Don't give no information. Because if something happens, somebody else is going to tell them, oh, wait a minute, those results are not good. Did they tell you that it were good? Just the fact that somebody tell you, even if they are not medical doctors, they're going to give ideas to the patient. The patient probably is going to start a lawsuit, even though if they're not going to win, but then they're going to put the office in all these hurdles and all these situations just because we did something that we weren't supposed to be doing. Medicare patient rights statement. So by law, we have to give the patient, when the patient registered, remember, they are posted on the office. What are the patient's rights? But the Medicare patient rights statement is that, the Medicare, remember, Medicare is the insurance that covers senior citizens, 65 and older. So they have certain rights according to Medicaid, to Medicare. Remember, Medicare is different from Medicaid. They are government, but each one is an insurance that covers certain population. Medicaid, they cover patients who are low income or no income. So they offer health insurance to this population. Medicare, on the other hand, 65 and old. So they have certain regulations, particularly because you have to meet the criteria that you are over 65 to receive certain benefits. We will discuss this when we get to medical insurance. Once again, that is going to be the next module. Other legal document, assignment of benefits. Now, this is so important for you as a patient. Because assignment of benefits, as the word implies, it means that, you will be informed what services your insurance is going to cover. That's why we do not send you to do something directly. We have to first get a approval from the insurance, whether you qualify for this particular procedure, this particular treatment. In other words, whether the insurance is going to pay. So first, we apply to see if the insurance is going to pay. And if the insurance doesn't cover those benefits, those medications, treatments, procedures, then we're going to inform the patient. The insurance doesn't cover this, but we have something else that the insurance covers. Or they don't cover whatever you need. So you have to be responsible for that, for the cost of those services. That's basically what it is. And the patient needs to be informed day one, the day that they register for to take care services from this institution. All that has to be informed. And remember that the first part of the registration says right there that whatever the insurance do not pay, you are responsible. So we have to tell the patient. It says right there that the information that we collect from them is going to be disclosed. It's going to be released to the people who is going to be part of the care of the patient. That information, we have to release it. So that's basically what it is. So assignment of benefits is very important because remember that I've been telling you this since we start this chapter, that patients always suspect that the insurance is going to cover everything. No, insurance covers everything, except for the government insurances. They usually cover everything. Now, Medicare covers 80%, but this is a different goal, ball game. I will explain it to you. You ain't gonna end up paying nothing, but it's because there is some arrangements that they have with whoever does this procedure. But for now, let's focus on these legal documents that are going to be included in the patient's medical record. That's basically what it is. Informed consent. Now, remember, consent is just, for simple things. Something that has many risks. If I don't have risk, then you just give me consent and we do it. Patient was asked to do this, the patient accepted. Well, we document that. Informed consent now is a form that they have to complete. Because remember, the doctor has to inform you. Benefits, risks of the treatment procedure. Options, if there is something else that might be done, instead of going to this kind of very serious, risky procedure, can I get something that, doesn't have many risks? But then think about it. If it is something less effective, you might not have risks during the procedure, but then you have risks with your health because you're not going to get better because the procedure is not the best. But the one that is the best is the one that carry all these risks. But a medical doctor will not. No medical doctor will select a procedure that has more risks than benefits. So we have to balance it out. If the benefits outweighs the risks, then we do it. But we give the patient the options. And that's why we have an informed consent, a written consent, an express consent, can be called either way. So for you not to mistake in these terms, if they said, okay, so the patient is going to have a surgical procedure, what type of consent you're going to give them? Then inform, because you have to inform the patient what's going to happen, what are the risks and the benefits. Remember, that's what you inform him. Now, if you don't see informed consent, now which of the following consents is the one that, protects more the patient and the medical office? Oh, written consent. Because consent can be implied. You just mention things that the patient agrees with. So consent by itself is not, it's just a general statement. Doesn't tell me much. Okay, Mr. Rodriguez, I'm going to give you Tylenol for the pain. The patient said, okay. Oh, there's something stronger than that. I've been taking Tylenol and seems like it doesn't work. Well, you were taking 500 milligrams. Now I'm giving you 800 milligrams. Now let's see if it works. Oh, I'm going to change. Well, I'm not going to give you Tylenol. I'm going to give you Motrin or Aleve or something else. So you are consenting with something. I'm going to draw your blood. Sure, not a problem. You sit there and we're going to draw the blood. So that is the consent. But the consent can be implied or written, remember. But when it comes to procedures, it has to be informed. Yes, it's written, but it's informed because I have to inform you what's going to happen during the procedure. Not only the benefits and the risks, remember. What is the procedure all about? What is about? Oh, you're going to do a heart surgery, open heart surgery. You're going to do a laparoscopic surgery. You're just going to remove something. You're just going to drain something from there. So that's basically what you tell me. You have to tell me everything. Who's going to be doing the operation? Doctor such and such. Who is going to be assisting this doctor? Oh, it's going to be doctor this. And the nurse is going to be doing this. Who's going to prepare the instruments? Oh, this doctor. The patient doesn't know, but we have to mention who is going to do the procedure, who is going to be part of the team that's going to be doing the procedure. Where is the procedure going to be done? Which location? Which hospital? And it has to be written there. Remember that the patient can withdraw these consents at any time. Remember, the patient has the right to refuse. Just because the patient signed an informed consent does not imply that the patient cannot go back to it. I can just decide not to. We have a patient who were supposed to do surgical procedure. We stabilize the patient in emergency, then we send it to the surgical doctor because now the patient survived. Now they can do the operation, they do the surgical procedure. The patient now was conscious. Patient was consent. Patient say yes, agree with, sign. The family member was there, sign. Then when the patient was in the OR, right there in the table, laying down after they were preparing the patient and all the stuff, the patient says, you know what, by the way, I don't want to go through this. So what is it that the medical personnel is going to do? The medical doctor, the in charge to do the surgical procedure, is going to try to convince you in a good way to do it, to continue with the procedure. They're not going to say, oh, well, listen, you wait until the last minute now to say no. We prepare everything. We have the OR already ready. Everybody's here ready. Why didn't you say, no, we don't have to go through all that? That's called assault. Remember, the patient has the right to refuse. So the doctor in charge is gonna immediately try to talk to the patient and tell them, that these are the benefits. But if they actually decide not to go with that, we agree, because they cannot force the patient to do something that they don't want. But immediately, someone is gonna bring right there in the OR. We have forms, we have all the paperwork. We're gonna ask you to sign a waiver, a refuse of treatment, which is right here. See? Refusal of treatment form. The same way that we have the informed consent, that we have this disclosure of information form, the assignment of benefits and everything else, we're going to have a form for refusal of treatment. Okay, Mr. Rodriguez, you don't want to get to the procedure? Well, I discussed with you again the importance of doing the procedure, the consequences of not doing the procedure, but also the consequences if you do the procedure. If you think that, decide not to go through, all please sign this document, which is refusal of treatment that you refuse, then please sign this paper. If the patient doesn't want to sign it, we're not going to force them to sign it. The medical doctor is going to be writing down where the patient's name is, patient refuse to sign. This is the refusal agreement, right? But then you're going to place on the line that says patient's signature, the doctor is going to be writing down a note, patient refuse to sign after discuss the benefits of the risk of not continuing with the procedure. And it's going to write, no, of course, that the patient was there, everybody was there, the OR was ready for the procedure, but the patient changed their mind at the last minute. So we can't force the patient. That's not the way that it works. So the patient is honored the refusal. Don't want it, don't want it. But the medical providers are safe, because after the patient signs the refusal, or the patient doesn't sign, because remember, the doctor, write down whether the patient signs or not, there's got to be a witness there. So someone in the crowd is going to be the witness. Said, oh, I was the witness, I was there, the patient refused, so I'm going to sign. And they're going to date it, and that's it. If something happens to the patient, it's the patient's responsibility, not the medical providers, not the hospital. See, that's what's important about, that's the importance of having all these documents. Now, what happened now for the room and for all these people that were ready? Who's going to pay for that? Well, the insurance is going to pay for it. The insurance is going to pay for it. Cancellation of one procedure in the OR, in the surgical room, is a lot of money. So we will prepare, ready, the patient refused. Well, The insurance is responsible for the cost of all this preparation. They're not going to pay for the surgical procedure because the surgical procedure was not done. But they're going to pay for all the preparations and for the time and for the space. We charge for the space. The OR, that room probably could have been used for someone else. But because this person was here and it was scheduled, but it canceled at the last minute, we're going to charge the patient for it. Some insurances charge the patients for no show to the office. If you didn't cancel within 24 hours, or you just decide not to show off to your appointment, well, you paid for it. The insurance paid for it. Sometimes the insurance bill you because you didn't go to the appointment. So you deal with insurance, not with us. So you need to know all the regulations, the policies, how everything applies. This is not simple. This is not like, yeah, it's your decision. That's your right to decide to refuse treatment. But then we weren't refusing. We were ready to do the surgical procedure. We prepared everything. We have everything ready. So the time for these people right there, the other doctors, the main doctor, the nurses, the anesthesiologists, oh no, that's gonna be out. The instrumentist got everything ready, set up, the tables, the space, the time. Oh no, that's gonna be money right there. So again, that's how it works. That's why we have these legal documents. Any questions about legal documents, primary record, secondary record? Because this is important. Now again, from here, just when we get to medical insurance, we're going to talk about these AOB, and of course, a lot more things, because that's important, and because it will be us. Yeah. Some of the documents that you have to sign when you join the medical practice, they ask about that. So we will discuss that in more details because that's more about insurance. But as we cover these legal documents, then we're going to talk about always protected health information. Remember, informed consent, consent, refusal of treatment. That's going to be all the time. But remember, that happens more often than you think. So we're going to keep all this information. Moving on with these legal documents. Any questions? Remember, you can ask any question at any moment. Other legal documents, we talk about this, remember, in one of the classes that we have, the advance directives. Advance means something that is done prior from something that's going to happen that we don't know, like the living will, DNA. So all these things, the healthcare proxy, the durable power attorney. Remember, that was law and ethics. So it's very important to understand that these documents needs to be contained within the medical records, because an advance directive is is a document, it's a legal document that the patient signs instructing, pointing someone, an agent, to do something, or leaving a document written by the patient with the instructions of what should be done if something happens to the patient and the patient cannot make decisions by themselves. Patient got into a car accident, the patient is in a coma, how the patient is going to make decisions. But if you have an advance directive, in this case will be a living will, so which is a document that the patient wrote themselves. The patient did it. I, Alberto Hoyer, at this day, at this time, I want, if something happens to me and I'm not able to make my own decisions, I want this to be done, or I don't want this to be done. Nobody else can go over my will. No one. So it has to be honored. But this document, in order for the medical providers to honor, to follow through, they have to have a copy in the patient's medical record. Other than that, what's the purpose? The DNR do not resuscitate. This is only for people who has problems with the heart. You have a heart attack, myocardial infarction, you collapse, it's a heart attack, do not resuscitate me. Let me die. Do not give me chest compressions, do not defibrillate me, do not give me oxygen, nothing. Let me die. But I have to have a copy of this document in your medical records. Other than that, how I'm gonna know? But if this happens on the streets, remember, you're gonna be brought to an emergency room. In an emergency room, remember, certain things when we don't know them, we're gonna weigh everything because we're gonna do our best to save the patient. And then we find out something, we're not gonna do anything else. But for patients who has DNRs, usually they have a bracelet that says, do not resuscitate. They carry it. Or within the wallet, they have a little card right there, do not resuscitate. Or they have a necklace with do not resuscitate. So again, when something happened to the patient, the first thing that we do, of course, if it is something very serious, it's going to end up in emergency. They're going to do whatever is possible because we don't have documents from this patient unless the patient is brought to the hospital where they receive services. Or a family member says, oh, my relative has this document. Other than that, oh, this is the patient's name. Somebody else is going to find out. But in an emergency situation, remember, things kind of, goes a little beyond. Other than that, these documents are going to be within the medical records. Organ donor, remember, is also part of the advanced directives, because advanced directives means that when you are competent, when you are with all your mental faculties, you decide to sign these documents, to appoint someone, to make decisions for you. Or you decide that you're gonna give this to donate your organs. Remember that an organ donor has to specify what is it that you want to donate. I want to donate my entire body. And to who and for what reason? You can be specific, because there are forms right there and they tell you what parts of your body you want to donate. That's your heart, your liver, your kidneys, your bones, your eyes, anything, your skin, everything can be used. So you decide, because you have to be specific, because the questions are there. So then in case that something happens to you, then we have this in your records. We're going to be able to decide, what is the next step after. Now, if someone else comes along and says, oh, no, the mother, the father, the wife, the husband, and trying to, persuade this from happening, then nothing that they can do. Now, the problem is when you do not leave an advance directive on an organ donor card, then it's a different issue. Then certain family members can make the decisions. If the woman is married, the husband has the right, not the mother, not the father. Vice versa. It's also true for, if the husband passes or get into a certain situation, the wife has to be the legal wife, right? Decides what to do with the body. So again, or what to do with the life of the person. Should we disconnect this person? Should we put them in a respirator? Should this surgical procedure should be done to save their lives or not? All the other legal documents needs to be in the medical records. Personal property list. Now, personal property list, what do you mean personal property list? This is kind of weird, right? Says, what personal property list? Well, think about when the patient is admitted. Patients are admitted and they have some personal belongings. So they might have a watch, they have a wallet, they have a chain, they have a bracelet, they have earrings, they have their clothes, their shoes, their bag, their purse, I don't know, whatever they carry with them. There is a document for all the personal belongings. And we're going to mark each one of them. And we're going to put it in storage. We're going to put it in a locker. Or we're going to return it to the family member. But we have to have a list. Because there are a lot of problems, particularly for the patients who have been admitted and they have some valuables. Some employees, they steal the stuff. So that's to protect the patient properly. So again, this is only in the situation that the patient is admitted. So we have to have that list, and it has to be in the patient medical record. Everything that we collect from the patient, each item is going to be documented. And after that, someone's going to come over and says, oh, no. But my wife, my husband, they have a gold watch, these diamond rings or earrings, and we never collect them. Because remember, when the patient is admitted, there is no one person. Usually I have 2 or 3 people there during the admission time, and everybody's going to be seeing what was removed, what was collected from the patient. Again, this is a very sensitive issue. So whatever belongs to the patient belongs to the patient. Has to be put aside or on a safe or returned back to the family if that's the case. But we have to keep a list of all the items that we collect from the patient. Disclosure record. Now, these are, remember yesterday, no, it's not yesterday, it was on Thursday. We were talking about, that whenever we release information from our patients to other entities that are not whoever is part of the care of the patient, then we have to keep records to who we release this information, what was the purpose, so we keep the release of information from. And if we disclose it, because we need for the treatment of the patient, and we need to inform the patient, we need to record that as well, that we disclose this information. Remember, if the patient doesn't want you to disclose, it's not that we are going to disclose information from you. No, this has to be discussed with the patient first. Mr. Mrs. Brown, we're gonna refer you to this specialist, and they're gonna evaluate you, and then probably gonna do this because you have this condition. I'm going to release some information to this medical doctor. If the patient say no and doesn't sign the paper, you just don't release it. But we have to let the patient in advance. It's not that we are going to release it and then going to say, oh, by the way, we release some information to this doctor. That's not how it works. It's before you send the patient to this, give this referral, or the patient requests for some information. Most of the time is when we, the medical providers, disclose information to someone for something, then we need to let you know and let you know what information was disclosed. So again, we inform the patient what information we are going to disclose before we disclose it, not after it's been disclosed. How are you going to bring back this information that you already disclosed if the patient refuses? Says, no, I don't want my information to be disclosed to the person. Actually, I don't want the procedure, but you already disclosed the information. Well, you're violating HIPAA. So not good. So we have to keep all of this in records, because if something happens and the patient says, oh, no, my information was released without my consent, I didn't know that this doctor, oh, no, here it is. See this document? I spoke to you, I contacted you, I discussed it, and you agree, and you sign, and I have a witness right here too that signed. So again, everything has to be documented. So otherwise, remember, when things do not go right with the procedures that the patient receives, then immediately they wanna, bring charges. Even though if I told you that these risks are, potential situations that might happen to you, you might think that that's not gonna happen to you. But if it happens to you, now you're gonna bring it against me. But because I already concern you about this, inform you about this, your case is lost. Remember all the 4 deeds of a lawsuit: duty, dereliction, direct cause, and damage. So we have to keep on, refreshing this, because we forget about this because we're not familiar with. I remember this because I've been doing this for a long time. But again, you definitely, not gonna keep this in mind all the time, because it's a lot of information. And you have to keep in mind these 4 Ds, or a lawsuit, or negligence. Because if you don't keep it, then, when you see it, you're not gonna know exactly what each D stands or means. So we have to keep an eye on that. It's very important. These are the legal documents. Now, clinical data. When we talk about clinical, is everything that is done in order to determine what's going on with the patient. That's basically what it is. So the patient comes with a complaint. Remember, I have this, I have a back pain, I have problems of hearing, I don't smell, I cannot move my bowels, I have a belly pain, a stomach pain, my leg hurts, I have a swelling right here, I have a stone lump right here, I don't know what it is. My joints hurt, and when, again, that is the clinical data, plus everything that the doctor examines you, orders, treatments, diagnosis, test results, that will be part of the clinical. So we already covered what is the medical history of the patient. Remember, medical history, everything that have happened to the patient up to now, what conditions you have, what medications you are currently taking, what procedures have been done to you, have you had or had in the past, what you currently have. That's medical history, anything that the patient have in the past and whatever the patient have now. So that is important. Not just the past medical history, but also current history or present illness. Physical exam. Remember, this is clinical. We're not talking about like whether the patient smokes, drinks, marry, a widow, works, doesn't work, have children, no children. That will be the social part. This is the clinical part. Now, the physical exam. So here is that this is often called the SOAP note. Remember, the clinical exam is everything that we do, all this acronym that we use from the moment that the patient comes to our office and complains about something. And then we start doing certain evaluations, ordering certain tests. We need some results to determine to have a diagnosis. And if we have a diagnosis, now we have to come out with a treatment. Remember, this SOAP note is very important. It's important to know what each one of these letters of the SOAP note stands for. Remember, S for subjective, O for objective, A, assessment or diagnosis, and P for plan or treatment. Any testing, whether it is imaging reports or lab reports from any from body fluids, including biopsies or tissue biopsies, everything has to be documented here. Any treatments. And the treatments also includes the medication that the nurse gave it to you. So we have the nurse's note, because if you are in patients, if you've been admitted to the hospital, then we're going to give you some medication, right? Whether intramuscular, subcutaneously, intravenously, topical medications, any type of medications. So we need to document everything. Everything that is done to the patient has to be documented. Remember, it has to be documented because the medical records is a legal document. So anything that the patient receives, any services that the patient receives, services, procedures, just the fact that the patient came to our office and is being seen by the doctor, even though if the doctor didn't prescribe any medications, those are services. There is always a reason why the patient shows up over there. But is it medical related? It's a clinical part. Referral consultations, case management. Remember, cases, you have a particular condition, and we're going to see how we are going to go about this condition, how we're going to treat it. We're going to, from the day one that you have the diagnosis until the time that you're being discharged, whether discharged because you die, discharged because we cannot keep you in the hospital any longer, discharged because you're getting better, anything. We're going to have a case. Remember, case is the reason why you were admitted to the hospital, because this happens mostly for inpatients. We have a case number. And that case number, we need it because that we're going to get paid, we're going to get reimbursed, not just for the services, medically speaking, that we provide to them, but for the time that you've been there. Remember, the room that you occupy, the TV, the services, that's not the clinical, but the stay in the office That's financial. So we create a case, how we treat you from the moment that you enter to the time that you will discharge. Remember that the discharge not always is positive. Probably the patient died, and now the patient is being discharged, but it's the dead body who is living. And that information has to be in the clinical data. The discharge summary, remember, discharge summary is not like, okay, so we're done with you and that's it, goodbye. No, the discharge summary has a lot of information. The discharge summary is going to have a, forget about the dates, because that's important, and the name of the patient, that is assumed, but it's going to have what was done to the patient. What was the diagnosis? What medications he or she gonna go home with? What is the post-admission treatment? What is the patient gonna follow now? When the patient has to come back, return. What does the patient has to follow after? So the patient do not leave the hospital like nothing happened. Oh no, you feel good. No medications, no treatments, no rehab, no this. No, there are gotta be some post, treatment after the admission. So depends of the patient, depends where does the patient go now. The patient is going home, the patient is going to rehab, the patient is going to a nursing home, the patient is going to have a home attendant, the patient is going to be in a wheelchair, the patient is going to be in crutches with a cane. All those things we need to record that information, because those are the discharge papers. What you have to do after, we're going to record everything that happens during your stay, and now we're going to give you orders what to follow after. Obstetrical records. Now remember that obstetricians are the one that deliver the babies. These are the medical professionals that take care of females that are pregnant. That is it. That's their job. They are pregnant. From the moment that they are pregnant, we refer them to the obstetrician, and they receive all the care and the treatment during the pregnancy. When the baby is born, that's it. The responsibilities ends. We got to keep all those records in the patient's files. So that's basically what it is. Whether the patient has a full-time pregnancy, whether the patient has a premature baby, whether it was a stillborn child, or has any defects, or it was normal vaginal delivery, was a C-section, all that information is there. Whether the patient developed preeclampsia, eclampsia during the pregnancy, whether the patient developed gestational diabetes. So it's a lot of stuff. It's not just, obstetrics, yeah, the patient is pregnant and, well, deliver the baby, that's it. Whether the patient has 1, 2, 3, multiple babies, whether the patient have had babies in the past, or it is primipara, it's the first time that is having babies, all those things, the age of the patient, whether there was a risk patient. Remember, there are some risk pregnancies. So patient has to be admitted prior to, giving birth. So all this is part of the obstetrical records. Now, when the female gives birth, now we have pediatric records. Now, it might be the pediatric patient itself that is going to have his or her own records as a new child, but also The mother might have, records about how many children they have. What is the age of those children? What is the age? What is the gender of those children? Whether those children have any medical conditions. Remember, you can have a Down syndrome child, or an autistic child, or a child with physical disabilities, mental disabilities. So all that information, we're going to keep it. Of course, we have a problem list. Remember, problem list is all the medical conditions that the patient has. Problem list. What problems do you have? Well, we don't say problems. What conditions, what medical conditions do you have? And which one you had in the past? Because remember, there are some conditions that, they are not chronic. You might have had them in the past. Now you don't have it. But we need to know if you have them in the past, because that can be the reason why it's the condition is returning back to you. So we have all the problem lists, all the medical conditions that the patient has or had in the past. We have a medication list, of course. If you have medical conditions, probably you were treated with some medications. We need to know what type of medications, including over-the-counter medications. Remember, home remedies, we don't give it to you. But we have to ask if you're taking any herbal medications, some, home remedies. So if that's important, that's pertaining, so we add those. But most important, those are the prescribed, even though if they are not prescribed, over-the-counter medications also are included in the medication list. Whether they are pills, tablets, gel, or liquid medications like injections, anything, powders, creams, ointments. We need to know everything that is being given to you for any of these conditions or any of these problems that you have or have. Public health records. Remember, public health records are these conditions that you have that are communicable diseases. These are open to the public, not within your name. Remember, these are these conditions that can be transferred, spread to one person to the next. Infectious diseases, that's what we call, or venereal diseases. These are public records. Your vaccinations are public records. Drugs are public records. Now, I'm not saying that there are public records that everybody's going to be seeing your information. Remember, we need private, what is your PHI. Public records means that can be, released to not directly to the public, but to the organizations to let them know that it's an outbreak of this condition. Remember, COVID is a public record condition. HIV is a public record. We're not going to mention who has the condition. We are going to mention how many people have HIV, how many people have AIDS, how many people have gonorrhea, how many people have chlamydia, how many people have syphilis, how many people have any of these conditions that are communicable diseases. So anything that can affect the public, it becomes public, but it is the conditions only, not the patient's protected information, not that. So remember, that's what's called public health records. It's information that can be released to the CDC, and the CDC is going to have all these statistics So you can go online and type how many diabetics are in New York City, New York State, in Florida, in the entire North America. How many diabetic people are in China, in Italy, Portugal, England, I don't know, any country, India, Brazil, Argentina, because this is public health records. We need to know. We have records, statistics, how many people contracted the COVID-19, how many people die per town, per state, per country. Now, remember, only we have the statistics and the numbers from those cases that are reported. That's why medical providers need to report these things. But there are many unreported, not because the medical doctors do not want to report them, it's because the patient do not look for medical help and they just die at home or somewhere else. Because anyone who comes to the hospital and is being diagnosed with something, that will be reported. So that's basically what it is. But when there's something serious, something, once again, that is communicable, passes from one person to the next, now it is a social risk. For that reason, we have to take measurements right away. Yes, diabetes is a very, very common condition in the United States and other countries. But are we gonna run desperately to report this? No, because you don't pass diabetes to another person just because you talk to them, because you sit with them, because you sleep with them, because you eat with them. No. But other conditions, yes. And these have, priority. They are risk. They are public health risk. For that reason, we have to keep all these records. Remember, when we have a patient who has HIV or tuberculosis, we have a different document that we add there within the medical records because it's a serious matter and we need to know how to identify these patients because we need to deal with them. It's not done. We're going to put a mark there for them to be a no. It's just that they're going to have an extra document there with the diagnosis of HIV and the results of HIV of all these tests, because we are going to keep an eye on this patient, because remember that the condition can worsen. Now, someone who is HIV now has the risk to become AIDS patient. This is like a patient who has cancer, but having cancer on the first stages might be treatable. But if you have a cancer that has spread to other organs, which is called metastasis, there's nothing we can do. That's it, it's over. So we try to prevent that a condition that the patient develops worsens, gets to that stage where it becomes a terminal illness, a death sentence. So those are the things that we try to do. So we have all these records there. Let's move to the SOAP no. So remember, here we go again. Subjective, objective, assessment, and plan. Remember. So think about what is it that you collect from the patient? What is it that the patient complains about? So that's how we're gonna know the answers for the test. So subjective, in other words, is something that cannot be proven. It's very difficult. It is subjective. I mean, how happen? I mean, it's what you're saying. but that's prove it to me. Oh, I purchased this in this place. How do I know that? I have to take your word for it. That's subjective. I have $10 million in my bank. That is subjective. I have $1 in my bank. It's subjective. How can you prove that I have a million, $10 million or a dollar in my bank? How can I prove that? It is subjective. So everything that we say is subjective. It becomes objective when we can prove that what you're saying is what is real, because I have proofs now. Oh, look at my bank statements. It says right here, I have $2 in my bank. I said, but you said you have one. Yeah, by the way, I got some interests in add up, but I do have now proof that I have something there. So it is subjective. So when the patient says, my body hurts, probably it's not the entire body, it's just part of it. Maybe it is your feet, maybe it is your legs. Maybe you're just weak because you lack these vitamins, these minerals. And you said, I feel, weak, I feel this. Might not be that. So whatever the patient tells us is subjective, because this is a perception of the patient. And that's what we call symptoms. Remember, symptoms. And whatever the patient tells you when they come to our office, we call it chief complaint. I mentioned this already. So this is again, and you're gonna see this, C, chief complaint. These are capital letters, not the little c, C. Because this means cubic centimeters. So it's C, chief complaint, capital letters. So every little detail counts when you're trying to answer the questions. Remember, the patient is complaining about headache, chest pain, whatever the case may be. What part of the song know this? Oh, the subjective. The reason why the patient comes to the office looking for treatment, what is called that? Chief complaint. Remember, if the patient comes here looking for help, that is called chief complaint. But whatever the patient says is called subjective, because these are called symptoms. Symptoms is something that you express, but it's something that I cannot see. I have back pain. Can you see pain? How do you know if the patient is actually having pain? It's subjective. You cannot see pain. So I'm going to do certain evaluations, certain exams, physical maneuvering on your body. Now I'm going to see that you do have a pain there. Okay, move this leg, move here. Oh, no, I cannot do it. Oh, no, it hurts when I do that. Oh, well, patient has a pain. But just because the patient tells me that it has pain, I'm very sad. I'm very happy. How do I know that? I don't know how happiness looks like. I can pretend to be happy, but that's not true. Because happy, you cannot measure happiness. How can I prove that I'm happy? Difficult. So whatever the patient tells you, subjective. Everything else is going to be objective. Why? Because objective is something that you can see. It's something that you can touch. It's obvious because you're going to see the results. I have a pain, but then I'm going to do certain evaluations, and then I'm going to say, oh, patient presents pain during, lifting or stretching the leg. We have other names for that, but I'm not going to go through all these technicalities. So that's basically what it is. So as moving the arm up, down, I ask the patient to do this, to grasp me, to try to hold me tight. No, the patient's strength is weak, the patient don't have reflexes. Now I come to a conclusion that something is going on because I'm proving it myself. This is a medical doctor. This is someone who study medicine and start checking for those signs. Now, objective is considered a sign. A symptom is subjective. I order blood. I cannot see anything in blood, but I'm going to get the results. Oh, the levels of cholesterol are higher than normal, lower than normal. They're normal. No worries about that. Glucose levels are above normal. I'm worried about that. Below normal. I'm worried about that. They are normal. No problem. I have results. I have proofs. I have an X-ray. I see a tumor, or I see a broken bone. I have a CAT scan. I see problems with the blood vessels, with the organs. Now I have proofs, I have results about something that is going on with you. Just the fact that you tell me that something hurts you or you notice something does not means much. This is the beginning. Now, it's not that we're not believing what you're saying. It's that what you're feeling probably is not exactly what you're having. That's basically what it is. So that will be objective. Remember, SOAP. The only one that is subjective is what the patient says. Everything else is objective. Assessment, that will be the physician's diagnosis. Whatever the doctor finds out after collects all these exam evaluations, including test results, radiographic results, the physical exam results. Now I come to a conclusion that this is what you just put it away. Because I know what you have, now I have a plan. What is the plan? Oh, I'm going to treat you with this. I'm going to send you for this. Or I need more investigation. I'm going to send you to another specialist to run this test, this procedure, probably surgical procedure. Remember, not always going to get to a diagnosis. Not always we're going to get a treatment that is, or a plan that is going to fix the problem of the patient. Most of the cases, we just give you medications to relieve the symptoms. So if you have pain, we're going to give you medications for pain, or pain medications. If you have problems with your skin, rash or something, we're going to give you cream to remove, not because we're going to remove the condition might come back, the condition might be chronic. See, people with diabetes, we give you medications just to keep you without those symptoms, so you can function. So you can, meet the requirements for your job, for your school, for your home, as a mother, as a father, whatever you have to do. Some of the times we don't get diagnoses. Why? Because sometimes we don't know exactly what's going on with the patient. Every single test, every single evaluation comes negative. Remember, those situations in which we do not know what's going on with the patient, we cannot come out with the diagnosis. It's called an idiopathic condition because just we don't know what's going on. So that's basically what it is. Okay, any questions? Because if we don't have questions, then we're gonna go on break. 7:08. So let's come back at 7:50, and then we wrap her up with this chapter, and probably gonna call it the day. Okay? Enjoy your break. See you 7:50. Okay? Good.
Thank you.
You're welcome. See you 7:50. Okay, so we are back from break. I'm gonna continue with this chapter. So we talk about the SOAP note. Remember, that's very important terms that you need to know, need to understand. And again, it's important because if you have to get any information from the patient diagnosis, medications, treatments, you're gonna find it right here. So sometimes the doctor may ask you, someone may ask you, okay, what was the diagnosis from patient, blah, blah, blah. Then if you have access to the medical record, you can look particularly the SOAP note. That's when you're gonna find information. Or someone from billing calling about diagnosis, they're gonna verify, you can get it from here. So that's basically what it is. Remember, there's always have to have permission and identify who is calling. If it is the insurance, well, that gotta go directly to billing, not to you. But billing probably is gonna be calling you for the notes or the patient medical records if you're still using paper, because billing department have access to medical records if billing department is within your facility. If it is an external independent contractor, then you might have to release this information, but then you have to talk to the medical doctor before you release this information. So when we talk about data, again, we're going to have some standardizations with the information that we collect. So especially or particularly when we release information to an independent or an associate. Remember that the insurance company is considered an associate to the medical because they are not directly involved in the care of the patient. They are involved with payments, which is different. So for that reason, they don't receive all the information from the patient. They only receive necessary documentation, the minimum necessary documentation. Remember that the person who determines what information is sent to these associate organizations has to be done by the doctor. Remember, we have some standards. So remember that the information that we're gonna release to these associate organizations is going to be the secondary data. Remember, this is secondary data is the data that we summarize. We kind of select certain areas of the medical record depending on what procedure or what evaluations the person who's going to receive this information is going to need. So that's basically what it is. Anything else, should be kept in the patient's medical record. So that's basically what it's talking about right here. Standard data sets means it's what data, what parts of, because it's not just one little piece. It might be the diagnosis, it might be the procedure, it must be the results of that procedure, the results of those tests. So we're gonna select certain areas and we're just gonna send this specific information. That's basically how it works. Now, again, this is called standard data sets because we're going to collect one part from here, one part from here, one part from here, meaning from each section of the medical record that pertains, that it is related to whatever procedure or payment is going to be collected or reimbursed. So basically, that's how it works, the standard. So here we have two examples. One, information that is collected in the ambulatory setting. The other one is information that is collected and released within a inpatient. So remember, this is very important, knowing the difference. Remember, in an outpatient, we just collect the patient's information. We have the patient's medical history, the patient's family history, the social history. So it is very simple. It's straightforward. And we're going to use the SOAP note for the chief complaint. The objectives is whatever evaluations the medical doctor is going to do, whatever test is going to do to get the results. Then we're going to get the diagnosis, and then we're going to get the plan treatment. So it's going to be some medications there or any procedures that we might require the patient to get. So that's basically how it works. Anything else is simple. Whereas with the inpatient, we're going to have a lot of more information here because we're going to have no reasons for admissions, what was done during the time that the patient was admitted, for how long the patient was admitted, what is the discharge papers, what is after the procedure that we have to do. So it's a lot of stuff. Whether the patient was in the emergency, whether the patient was assigned to one of the specialties in the ICU. So we have lots of things to deal with because there are more charges, remember. There are more things that are done. There are some nursing notes right here, which the outpatients do not contain the outpatient's health record. So for that reason, we need to know the difference between those. And we already discussed what is done in an outpatient, what is done in an inpatient, what we charge for. So that's why these medical records in an inpatient contains more information. Now remember that medical records utilized within the outpatient is going to be used for the whole term as long as the patient is being seen in this practice and the patient has not stopped coming, at least for a period of less than 3 years. All this information is going to be there. Now, a patient who is hospitalized, we're going to create a different medical record every single time the patient comes and it is admitted, because it might be admitted for a different condition, might be admitted for the same condition, but there's a different timing, different length of stay. So lots of changes. So we don't want to get involved in all that. So every single time a patient comes to the emergency, we create a new medical record. Anytime that the patient is admitted to the hospital, we create a new medical record. So that's basically what it is. In an outpatient, we keep the same medical record as long as the patient continuously come to our office for a period of less than 3 years. Then we're going to know that we have this patient. Because remember, after the patient stops coming to the office from the last visit, 3 years after, these medical records considered closed. Less than 3 years, 1 to 2 years and 11 months is considered inactive. And a patient that shows up every year or every month or every week and is continually coming to our office is called an active chart, an active patient. That's basically how it works. So it's very important for us to actually understand how this works, because in each setting, things works a little different. Okay, so health information management, every time that you see HIM, HIM, these things for health information management. This applies only for electronic medical records. So for records that are computerized, just put it away for now. So it has policies and procedures. Remember that we have policies and procedures for paper-based medical records as well. So that's basically what it is. So HIM of the Health Information Management Policies and Procedures establish the documentation requirements for the medical records. That's basically what it is. So they want to make sure that you organize these medical records in certain sections that are easy to find. We are going to use the same reverse method of storing information, reverse chronological format. That's not going to change. It's going to be the same whether you use electronic or paper based. So again, medical records, electronic medical records, paper-based medical records follows the same policies for, patients' privacy confidentiality. No difference. It is used for legal purposes, whether it's paper, whether it's electronic. The statute of limitation might have some variations due to the fact that electronic medical records, while it is stored within a system, a hard drive, or the cloud, or any other external devices, that we can store it because it doesn't take much space. Whereas these paper-based medical records are very difficult to store because they take lots of space and they get damaged. So we might not be able to keep them for a long time. Whereas these electronic files, we can take it for a long as you want it to. So that's basically what it is. So we're gonna have all these policies for how to store the information and how to retrieve the information, because now we're gonna have an account. Now we're gonna have a login and a password. So we gotta make sure that when we enter it in the electronic, devices, we can't just open the computer and start, entering information or looking at information. No, this information, you're gonna be having access because you have a login information. So it's different how to keep this medical record safe. And the way that we do corrections is a little different. Remember, we went through paper-based in electronic files. How do we correct them? If it is paper, we're just gonna draw a line through the error. We're gonna write down correct, or we're just gonna add what is the correct information on top or the bottom of the word or the statement that we want to change. Remember, we cannot erase, we cannot white out, we cannot delete. There's no way. We cannot kind of, obliterate this information. So it has to be just one line through the center of the word or the sentence or whatever it is. And then we do the correction. Then we place the date and our initials, who did the correction, what day was done. Remember that correction has to, the date that you enter there is the date that the correction was done, not the date that the entry was documented. That's not how it works. In electronic, we're gonna do it different. Remember, we're gonna use an addendum, which is gonna be a pull down menu when we're gonna add, not delete. We're gonna add an addendum. We're just gonna create a little note. We're not gonna erase, we're not gonna obliterate, we're not gonna delete. Remember, you're not gonna have access to these features to delete, because in computer you might say, oh, well, I just go there and delete the word and just put the correct one. No, we have to see exactly what happened the first time, the original entry that you made. It has to show over there. And if we make a mistake, we have the correction. And if you never encounter the mistake and something happened to the patient, well, then you're gonna get in trouble. But the information is gonna be there. So again, this is very, very important that we understand the policies. Not because it's paper-based, oh, we have some policies, and the other one, no, they don't apply. No, it's just that they are following, they are follow or they are done a little bit different due to the fact of, the way that the information is being collected and how it's being retrieved and how do you get access to it. See, if you have paper-based, you just go there to the shelves, to the cabinets, and you just pull out the medical records. And you have to leave there an owl guy if you remove it with information who took, when was the medical file removed, who removed it, to where did this file went. So that's basically what it is. In an electronic medical record, you don't do that because you don't need to remove anything. You just need to have access to enter and open that patient's medical record. So it's going to be some type of security involved now. So it's going to be privacy. It's going to be confidentiality, just like in paper-based medical record. But now we're going to have security because there are other methods of securing the patient's data. Remember that each individual depends on the profession that you have. You have certain access. You're going to have limitations, how far you can go. There are some medical files, some parts of the medical records you're not going to be able to see. So if that's not something that you need, and it's not something that you are authorized to read, to review, you're not going to have access to it. Don't even try, because it's going to be registered there that you try to enter files that you're not entitled to see. Remember that everything is recorded within the system. Every movement that you do, whenever you enter the system, is going to be monitored by an administrator from the IT department. And if something happens, they're just going to call the person who signed in at that moment, because that's the person that's going to show there that is being, trying to access files that they are not authorized, or that they were seeing files that they were not authorized to see. Remember that if you have to deal, you just have access to Mr. or Mrs. Brown, that's the only person that you have to enter to see, and only the areas that you need to collect information, to retrieve information, or to enter some information. If you go beyond that and start reading and reviewing stuff that you weren't supposed to, well, it's going to be registered over there. Where were you? For how long you were over there? Because sometimes, you can go like scanning something, you're looking for something, and well, that is susceptible. But if you spend 10, 20 minutes, 15 minutes, and then, by accident, I was looking for something. Yeah, you spend too much time over there. 10, 15 minutes, 20 minutes reading. You weren't scanning something. You weren't looking for something. We're just reading, reviewing something. So be careful. That goes for medical personnel. And it's not for the medical assistants. It's not just for the nurses. It's for the medical doctors as well. If patient Mr. or Mrs. Rodriguez is not my patient, I'm a medical doctor, that's not my patient, I have no business whatsoever to go and read that medical record. Why? What am I reading it? What I'm trying to find there? What I'm reviewing? That's not my patient. I shouldn't be there. Oh yeah, you're a medical doctor. No, wait a minute. That's not your patient, so you don't have access to it. You shouldn't be reading information that doesn't pertain to you or to your scope of, whatever you're doing at the time. So be careful. That applies for everyone. I have a login, and then when I enter, if I read stuff, these are not the patients that were assigned to me today. These are not my patients. I've never seen them before. If they are my patients, I can go, because I can go and review lab results, diagnosis, treatments. My patient is coming, then I need to know, okay, get familiar what's going on. Maybe it didn't work the medication. Maybe a patient didn't get the procedure, or that didn't work. Let's work on something else. So I had to go and review, but that's not my patient. So I have no business whatsoever to be reading or reviewing the patient files. So can you imagine if a medical doctor cannot do that? Well, medical assistant nurses, anyone who do not have permission to do that should be or be involved in this type of behavior, because that's not good. That has consequences. Now, patient record ensure community of care, continuity of care. Well, of course, the patient record, that's what it does. If I have your information, I just move from here forward. Can you imagine not having the information of the patient? The patient comes in this condition. How do I know if this patient had this in the past? The patient has taken this medication in the past. The patient has a reaction to this. Oh, the medication did not work. Now I'm going to start all over again, doing all the exams, all the testings, all the evaluations, and I'm going to give the medication that it didn't work before. So I'm not doing anything. So it's very important that we collect information, because we don't have to repeat or waste time trying to figure it out, something that was already done. So we're going to move from whatever we have forward. So that's what is so important about the patient's information. Can you imagine if we didn't have any information about this? There was no publishers, there was no books written by these publishers about medical conditions, about how the medical records work, how paper works, how electronic medical, how all the parts of the medical records are managed. How are we gonna do it? It's like every single time that we do something, we're gonna start from scratch, because we don't have a precedent. We don't have that history. So we don't have anything to follow after. It will be really difficult, and the patient will be at the risk all the time. But because we have all this information from our patient, we already, it's like, having the records from someone that has had this condition, taking these medications, and smokes, doesn't smoke, drinks, doesn't drink, works, doesn't work, female, male, all that information is so important for us. Can you imagine asking the questions over and over and over every single time that the patient comes in? Oh, do you remember what medication you're taking? Oh, no, not now. Like 10 years ago, because you said that you have this condition at the time. What condition was it? If that was diagnosis or something that you think that you may have. No, that will not be safe for our patients. Now, it's not just us that see the patient for the first time or the second time, but other people that is going to be interacting, taking care of this patient. If I refer my patient to someone else and I don't give my referring physician information about what is being done, what the patient situation is at this time, medical wise, then that doctor has to start from scratch. So if the patient has something serious, probably the patient is going to get worse, or probably is going to die by the time that this person start investigating what's really going on. And even though if they try, they're not going to get all the information, because information that was collected prior 10 years, 15 years, 20 years ago, 30 years, 50 years ago, how are you going to get that information? So we're going to be missing a lot of stuff. And the only one who's going to be in big trouble is going to be the patient. So that's basically what it is. Because we're going to see exactly where the patient is standing regarding all these conditions. And now we can share the information with other medical providers that are involved in this situation. So that's basically how it is. So all history for everything is important. Can you imagine if you don't have records that you went to the school, that you studied this, and you need to present records certificates and said, oh, I don't have it, but I know that I went to the school. I paid for it. I have this professor who taught me those classes. That doesn't mean anything. When was that? What subjects did you take? What was the grades that you get? Tell me about the subjects that you cover. Oh, you're not going to be able to remember. You're not going to be able to remember conditions, medications, procedures, family history. You're not going to remember any of those because we don't have to keep all this information all the time. It is too much information. Only the information that we're using continuously, we're not going to remember it. But when it comes to medications, conditions, because the terms are so difficult to remember, because these terms, sometimes not even English, they are Greek and Latin, how are you going to remember those names? How are you going to remember those medications? These names of these medications are very difficult. How am I going to remember this medication? Oh, no, I have diabetes. What medication you taking? I don't know. There's some medication that I take sometimes in the evening, sometimes in the morning. Oh, there are some injections that they give me. Well, probably I know. What is the dosage? I don't know. Wow, not good, right? For the patient. So we need to keep all this information on our patients, all this data, so we can continue the care of our patients without any issues. Sometimes if having the information of our patients develop complications, can you imagine not having the information? That will be detrimental for the patient. So it is important. Now, because we are keeping the information, remember, we're going to keep an information from the time that occurred up to now, because we keep records. So that's called a longitudinal account of the patient previous, visits, exams, diagnosis, procedures, all of that. We're going to know exactly where this evaluation took place. Who was the medical doctor? What was the name of the office? It was a clinic, it was a medical office, it was the emergency, it was the urgent care, it was a hospital, it was this particular specialty. What was you treated for? What were the results? So we're going to keep account of everything that has been going on from you, from the time that you developed the condition to now. Whether the condition was controlled, cured, treated, or not treated, or you didn't complete the treatment, something else happens. Whether you have family members that contain, that have that condition, probably you inherited the condition from your parents. Again, so important to understand what is something that you can control. Remember, smoking is something you can develop a condition of the lungs or other parts of the respiratory tract just because you smoke or because you drink. Your liver, your pancreas, your kidneys can get damaged. So we need to know. We need to keep records of all that information. Whether you come to our office frequently or not. Patients who do not come to our office frequently is because they don't have serious conditions or they don't have conditions at all. So we have to start from there. When you look at the patient's medical record, when you see the number of pages, if it is a very fat medical record, or you see the electronic medical record that they have a lot of information there, lots of visits. In 1 month, the patient shows up twice. He's been seeing this patient for the past 10 years. You're going to have a lot of information, whether you have a condition. So you just look at the progress notes and read all the diagnoses, because all the diagnoses are going to be there. It's not going to be only the diagnosis that the patient has now, but the patient has diabetes, hypertension, The patient has high levels of cholesterol. The patient has osteoporosis. The patient has, I don't know, vertigo. The patient has other conditions. So all of the diagnoses are going to be there. It's not just one diagnosis, the day that, oh, what was the reason? Yeah, that's the principal, the primary diagnosis. But then we're going to have other secondary diagnosis, which is whatever you have in the past, whatever is related to whatever you have, and things that you have in the past. Because there are certain conditions that are chronic. They don't go away. They are there. So a patient who has diabetes is going to have diabetes. And a patient who has hypertension is going to have diabetes, hypertension. Patient who has high levels of cholesterol. Now you have heart problems, CAD, coronary arterial disease. So we're going to have all those. So you're going to have all those diagnoses lining up. So if I just see the last page where the patient was diagnosed lately, I'm going to have all the diagnoses that you have in the past. And according to the diagnosis, as a medical doctor, I'm going to know what conditions you have and probably what tests do you have, what procedures you have had done, maybe some surgical procedures. So that's what's going to give us an idea. So we don't have to go and review the entire medical records. We don't have time for that. It is too much. I just glance the last history of my patient, the last progress note, and I have a picture of who's the patient. If I'm not pretty sure, I just glance the labs. I said, did they have an X-rays? Did they have a CAT scan, sonogram? What blood tests they have? Urine, fecal material? They have biopsies. From where? So I have an idea of what was done just by looking, scanning around. I don't even have to read. I just look here and say, oh, this is this. I have an idea of what my patient. And the patient is complaining about this. I'm not worried about all this information. I'm worried about what the patient has right now, whether it's related with something that the patient had or had in the past. That's it. That is the importance of having all this information handy because we're going to use it. So we don't have to be asking the patient because the patient is not going to remember everything. And if he remembers some things, patient don't have dates. When occurred, where it was treated, who was your doctor, for how long you have the condition, what medications were given for that. There were any procedures done for that. So think about it. Who remembers that? So sometimes I even forget to charge my battery on my computer and it's happening right there within few hours. Can you imagine? Now I keep my computer plugged in, so I don't want to have no issues. So that's basically what it is. So we need all the information possible from our patients, all this data to continue the care of our patient, whether we are the one who's taking care of the patient or someone else. Remember, there are many other entities, associates that have to do with the medical records of the patient, not just us. So that's the way, and that's the importance about medical records. Now it's personal health records. Now we are talking about something different. It's not just the medical records. This is what we began with. Personal health records. Remember, some of the organizations now that we have electronic medical records or electronic health records, usually is when we have electronic health records that we have access. So if you have your personal health record, that means that you have access to certain information about you. We discussed this already. Remember, the information that you have access as a patient is limited. You're just going to see there results of tests that have been already discussed with you. You're going to have diagnosis. Yes, any diagnosis that you have. You're going to have the medication that you're currently taking, not the medication that you took before. Nothing related to your past history, we are going to have it because that's not relevant for you. That is relevant for the medical providers, not for you. So you're not going to have that information. You're just going to get confused with so many things. So we're just going to have recent, current medication that you're taking, current diagnosis, procedures, the current tests. Remember, you're going to have only the results that have been discussed with you. Even though if it is negative, you won't have access to it because the doctor has to review it. And if the doctor sees that nothing is going on right there, it's going to post it in your portal, and then you're going to be able to see it. But if they have any red flags or there is any issues with your results, before I post it to you, I have to or the customer service representative the patient can make an appointment right there in the portal. So you can do that. You can see the medications. You can see whether you need a refill. You can do your refills right through the portal. Now, this portal has to be read, has to be evaluated, has to be reviewed. So let's say that I do have my my personal health records, of course. So let's say that I want to make an appointment. First of all, I'm not going to call. Why should I call? That's a hassle. I just do my appointment at any time from my home. Access my computer, my phone, open there, I have my login, go to the appointments in my medical records. I said, oh, I want an appointment. I select the time that I'm available and the one that is available in the schedule system. And I put there my request. Just because I enter the information does not imply that, oh, I make the appointment, so I'm going to show up. No, I have to wait for a confirmation from the hospital, the clinic. So someone is continuously checking the personal health records, and someone selected an appointment is going to show up like when we have message. It's going to have a notification that somebody sends an email, a text message, that we miss a call, or there is a message there, a voicemail. It's exactly the same. The computer is going to show us that we have something there. So then we're going to go there, check it out, says, oh, wait a minute. A patient make an appointment. Let's see. We're going to confirm. Why we're going to confirm? Because we have to tell the patient the test. Maybe we're gonna run a test. Maybe the patient needs to bring certain documentation. So before the patient comes in, we're gonna do that. That's why the patient automatically, the system do not approve your appointments. So you have to wait for our confirmation. And because we are in the computer all the time, because we all the time accessing the system, we're gonna see there the message, the notations. So we're gonna see, oh, I have a message. Go there and confirm to the patient. Then you see, oh, this is a new patient. Oh, this is a patient who comes for results. Then immediately you know, oh, let's see if the results are ready. Now we're gonna add this patient. We're gonna add this patient to the schedule of this particular doctor. Then at the end of the day, before the next day appointments, we're gonna print out the list of these patients that are coming, and we're gonna place it in the medical doctor's desk. And they're just gonna call by the order that that has been scheduled. That's how it is. So the patient can see some information. Again, that's for the patients only. And the patient can make changes, not changes like Oh, I don't like those results, I'm going to change it. No, you cannot change results. You're going to change information about you. You change your phone number. Now you can update it. So there is a tab right there that says, update your information. It doesn't mean that the information that it was there before is going to disappear. It doesn't happen that way. Some of the systems keeps the old information and you add the new information and it says information updated and it shows up in a different location. Why? Because sometimes we have certain information, certain documents under that particular address, that particular email. So we need to know that, that we keep current with that. Even though if you add a different number, well, the prior information that we send it through this email, through this phone number. Versus, completely losing the information. Remember, past medical history, we don't remove, oh, you have something like 10 years ago. Oh, no, that doesn't count anymore. No, of course it does. So we keep it. It's just that we're not going to use it, or we're going to use it if you need it as a reference, as a precedent. So that's basically how it works. And it's so simple. Now, we have a little problem with electronic personal health records. What is the problem? Age. Certain patients are not familiar with computers. So because they are not familiar with computers, they're not going to be able to see the information. They're not going to be able to log in, to create passcodes, emails. So we assess them to a certain point. But they have problems getting access to it after we create the account. Because the account, you can create it, you can come to the hospital or the clinic, somebody can just walk you through, but then they don't know how to log in when they go home. So older people, elderly people, forget it because they are not computer savvy, right? So it is a little troublesome for them. But for the rest, it's very, very important. Now we're going to have the information right there, and you're going to know exactly. You're going to have the information from the pharmacy, remember, because we're going to prescribe medications. We're going to do refills. So we send you the notification, or the pharmacy send you the notification that, your medication is ready to pick up. So it has lots of advantage using a personal health record for some people. If you know how to navigate with these applications. Remember, it's not easy if you're not familiar with computers. Once again, particularly for the elderly. Well, the little kids, well, parents have to do that. They are the ones who check what's going on. So it says right there that the personal health records integrates with other electronic systems. Of course, as long as they have this form of interoperability, which is very important, because remember, if I have a system, has to be interoperable with the other system. So I don't know if some of you remember not long ago, or probably still, some of the software applications, some of the applications that we use for Android do not work with Apple, and vice versa. Well, the same happens with, these systems, Windows or iOS and Apple. So this is the way that these devices, electronics, are built for security reasons. I remember that was a long time ago when we have computers like, the Apple in the other systems, the the Windows. And then I was like, okay, I got an Apple because I was like, oh, no, has to be an Apple. Then I have some applications for the college that I was, given by someone else that I could use, but they didn't work in my computer. So when I tried to open those applications, I put the CD, because remember, back in the days, we have CDs that you put inside, and no, I couldn't open the application. It's not compatible. So there's no compatibility or comparability, interoperability. Is this system from this hospital is different from the system from that hospital. So if I have to transfer information from here to the other office, it's not going to be possible. So that's basically what happens. So if we don't have this comparability or interoperability, inter means in between two systems. Compatibility is that even though if I send you the information, you receive it, you're not going to be able to open it up. Having happened to you that sometimes you try to open a file and it doesn't open, it says, oh, these systems do not support that application. And then you go, oh, what do you mean? I thought that these systems, all of them are going to open everything. No. Just because you're using certain systems, you have to have certain applications. See, if you don't have Google, if you don't have Edge, if you don't have Bingo and some other software application, you're not going to be able to enter and search for something. If you don't have the application for YouTube, you're not going to be able to play videos. If you don't download your application from Twitter or Instagram or Facebook, you're not going to be able to use it. So you have to have it. And certain videos that you download or you watch and you want to save them, sometimes you cannot save it. There's no compatibility. There is interoperability because you can receive this particular file, but then it's not compatible because you cannot open it. So what is the purpose of having something and you're not going to be able to open it up? So not good, right? So the system creates lots of bottlenecks, but it's being fixed, most of them, because these software applications, they have to, now when they build the software applications, they make sure that it works with the system and it works with the system. Because I'm a vendor, I'm a business person. If I'm going to target just this business, then I'm gonna lose. I gotta target all of them. So I have to have something that works for Apple, something that works for Android, for Windows, for Apple. So that's how it works. If you use paper, it doesn't matter what office do you have. You just write it down in paper and you just have it there. But it is issues too. So again, even though if it is electronic, not always, we can get all the benefits, all the perks. But these software applications for electronic medical records takes in consideration what I just told you, that they are compatible with other systems, because, I don't buy the same applications that other people buy. This hospital might buy this particular application for medical records. This other one buys some other brand. Now they have to kind of meet a common ground, that they have to be compatible for any systems out there. So all these electronics, all these software applications are, built now with that purpose, that they are interoperable. Because if they are not, not good. So that's basically what it is. So integrate that. Now, with electronic systems, because that's the importance about electronics, now we can do something that is called telemedicine. Probably you heard. It became very popular. It wasn't as popular as it is right now after the COVID-19. Telehealth and other things that we're going to see. How do we use technology to provide medical services, to people without having the people right there in front of us, without having them to make an appointment to come to our office. So in other words, these medical services are going to be remotely. We are having a remote class. This is an online class. Well, we can interview with the patients. We can diagnose the patients. We can order tests and they can go do it. If we use telemedicine. Remember, telemedicine, it also is called telehealth. And it's very popular right now. And we get paid for it. Remember, this is a new modality. This is a new approach to render services without having the patient face to face. Well, that was not something that the health insurance companies were covering before. Now they pay for these services because it's approved, because there is a need, because there are certain patients that cannot reach our office, but they have a phone, cellular phone, when they can do like FaceTime kind of thing. That's basically what it is. Or a computer. For people that not only cannot physically, mentally get to this place, but themselves, they don't have someone else. But for remote people where they don't have services, like in small towns, in the villages, in the rural areas. So that's exactly what we're going to do. So I can examine any patient. It can be outstay. Oh, but if it is outstay, this patient has to be in a state that I have reciprocity. So my license can work over there. Remember, I can see patients here because my license is from New York. But if I have a patient who lives in California, in Florida, well, the patient is outstay. Yeah, but you are sitting in New York. But no, my patient is over there. So the insurance is not going to pay for it. So has to be within, these limitations. But still, I can see a lot of people from New York. I don't need to go to their homes. I just from home, from the hospital, from my office, I can talk to them. I can evaluate them. I can actually conduct a surgical procedure. There's a doctor there. Do this, do this. I'm just going to walk them through. Then that can work. So I don't need to go to that particular place as long as they have the equipment. We don't need to have special medical doctor. I'm just going to instruct someone to do something, of course, something that is not as serious as doing a open heart surgery or brain surgery. No, then you have to move the person to a, hospital in the, in the city. But other than that, any other conditions, oh, I have fever, I have cough, I have this rash, I have this, as long as we don't have to do procedure right there, or this procedure is not something that is needed, like, you're bleeding profusely, you have a fracture, because then you have to look for attention because it has to be taken care immediately. But if there is any condition that I'm going to prescribe medication, it is easy because then I'm going to prescribe the medication and someone is going to deliver it to your home in your area, because through the system, we're going to do that. We're going to send these electronic prescriptions. So that's basically what it is. So that is not a problem. Again, it might be a problem, that the person do not know how to use the electronics to do this type of, uh, telehealth connections. But other than that, it's just not bad. Remember this, telehealth medicine is not going on, hasn't been going on for a long time. But online classes, yes, it's been going on for a long, long time. It's just that it's becoming more popular nowadays. Other telemedicine examples, teleradiology. See, teleradiology. Now, it's not that we're going to do an X-ray, a CAT scan, an MRI through, these these electronic devices. No, that's not how it works. How it works is that, the results, I don't have to wait for paper or for these large films. Like, remember, for some of you saw these films, that you have to roll in. Oh no, you cannot roll them. You have to keep it in a big envelope to protect them damage and things like that. We don't have to do that anymore. Now, if I order an X-ray, scan, MRI, any of these images reports, they're going to come to my computer directly to the medical record of the patient from the imaging center right there to my computer. And the only thing that I have to do is just open it up, because I'm going to receive a message that I have this test already there to me see. So I'm just going to open my patient. I'm going to go to radiology. I'm going to go to X-rays or CAT scans or MRIs. Click right there. I see it. So now this is how the radiology department is going to share these images with the medical providers. So that's basically what it is. I've been seeing this I remember since I started working. This is not something new. Now, again, this is because of the advent of electronic medical records. So there is a system, there are many other systems, but this is a systems application that is called PACS, which means Picture Archiving and Communication Systems. So this is the system that helps, to store that image, that X-ray, CAT scan, MRI, in the radiology department's computer, and now it can be transferred. So I'm going to send it. Just like we send files, just like I send you the PowerPoint presentations, like I can send you messages through the email with an attachment. And it goes directly to your email. If I send you text message, it's going to go to your phone, right? To your phone message. But if I send you an X-ray, an email, it's going to go to your email application. So that's exactly what it does. So if I order X-rays, CAT scans, MRI, any of these imaging reports, they're going to come right to my computer. Why? Because we have a comparable system and it's interoperable. So most of these organizations have PACS or have something else, but they're compatible. So if you're using this system and I'm using this system, they're going to send it. I'm going to be able to open the images. And not just that I'm going to open the X-ray, the film, the picture itself of the lungs, the heart, the kidneys, the bones, anything, the brain. And I'm going to be able to zoom out, zoom in, anything. I can do a lot of things with that. I can look very, very detailed areas. So that is the beauty of technology. So that is teleradiology. So we have to be able to understand how the telemonitoring. Now, this is very similar to the other applications, But now we are going to be evaluating our patients' health. Like, for instance, I need vital signs from my patient. I'm controlling my patient because is having problems with hypertension. I can ask my patient to check his or her blood pressure, and they're gonna send me this information through their phones as long as they have a internet service. That's it. Now I receive that information, I review it. Now I make a decision if the patient needs treatment or else. So that's basically what it is. This is remotely. So the patient don't need to come here to be checked for glucose levels, for blood pressure, for pulse, for temperature, for weight, because the patient, we all ask the patient, oh, can you please check your weight? The patient gonna check it and send me the information. Everything is gonna be through the portal or through the system. So it's very simple. And I get the information and I don't need the patient to come to my office to do that. So just, we do it that way. So this is telemonitoring. So you see how important it is when we have electronic medical records versus paper. Paper, well, you have to call probably, but we don't trust like that. So probably the patients do not know how to do the procedure. They don't have the equipment that they're going to need. Well, that's a different issue. But if they do, it is easy. Or they can go to this particular place, do all that, get all that information, and it can be sent to us. Either or. So these are some of the devices that we can use to check, particularly when you do heart. This is maybe the Holter monitor, or maybe it can be used. That's basically what it is for the Holter. When we do like evaluation of the activity of the heart for a period of 24 hours, and the patient just go about all their daily activities, and then whatever is being recorded is going to be recorded in this device, and then this device can be plugged to a phone, and that information from this device is going to go to the computer, the doctor's computer, and I can have the information. Or when the patient returns to the office, we're going to remove this device. It has a little chip inside. We place the chip in the computer, and we're going to get all the recordings for all the time that the patient has this device within. So that's basically what it is. We have all the devices placed on there. We will talk about this when we get to electrocardiography, because this is part of electrocardiography. So, advantage of e-visits. I mentioned this already. E-visits, well, I mentioned part of it. Making appointments is one thing. Now is consulting with the patient. So I can do it through telehealth. Remember, back in the days, we didn't get paid for consulting with the patient over the phone. Now we do. So if I'm talking to you, whether in the computer, like chatting, or over the phone, e-visits, the insurance is going to pay for that. But in the days before we have electronic devices, we didn't get paid for it. The doctor can spend hours talking to the patient about condition or about something after the procedure. They get paid for it. Now we bill for those services. So it is really, really important right now. See, back in the days, the doctor has to do house calls. Still, it's going on, very few, but not as much, because now we have all these electronic devices that we can use just to collect information from the patient. And we record it in the electronic medical records, all the information, because as we chatting with the patient, all the information is being documented. So again, very simple. We have nurses on call, nurses doing visits. We get paid for all that. We can contact the patients all the time without calling them, without wasting time. You know how much time we waste when we, or yeah, I might say waste, not spend, when we try to contact the patient, or when the patient try to contact our office, because we are not just waiting for you. There are many other things going on. But if you can do it directly from your home, you don't need to come to our office. What's going on now? If it is something serious, I'm gonna advise you to go to the nearest emergency room or urgent care, or make an appointment to come to our office, because we have to do some evaluations, some testing. But we're gonna discuss most of the stuff. You just come to get the procedure done or the test done. See how important it is to have electronic devices, but also to know how to use it. So every information that we ask is like, electronically, we are typing everything. We're talking to the patient, we're chatting with the patient, and we are documented in the subnote. And if something I need to order to the patient, I just order it and I tell my patient to come to stop by the office. But once again, it's gonna be, saving some time, because now I don't have to go through all these questioning. So you just come straight to get the laptop. So I generate an order to do blood, to do urine, to do an X-ray, CAT scan. I have everything ready for you. If there is medications, I just have connections, interoperability with the pharmacy. I just prescribe the medication. Remember that the patients usually select the pharmacy that they want to go pick up the medications from, usually a pharmacy that is close to where they live. I just send a message, okay, Mr. Mrs., whatever the case may be. Okay, I prescribe these medications, please go to the pharmacy. Some pharmacies even do delivery to the patient's home. So whatever arrangements you have, that's how it goes. But I can do all that. You don't need to come to my office. Now I'm gonna keep in touch with you every single time to find out how you're doing, whether the medication is working or not, or whether, other things that I need to do. Maybe bringing you in person to the office if things do not seem to solve in short period of time. So that's basically how it works. Now, I mentioned already, for this, if it's not maybe reimbursed, no, it is reimbursed. Now it is reimbursed 100%. Nobody's gonna do an e-visit, do all this paperwork, all these questions, all this prescription for nothing. Most of the insurances pay for it. Now this is becoming like a standard, because it facilitates for the patient, for the medical provider. Can you imagine patient coming into the office, too many people, you're not gonna have the time. Well, we're gonna select this particular time, we're gonna make an appointment, and I'm just gonna meet with you at that time, just like we're doing with the class. We meet at this time, you guys gonna be here. So that's basically what it is. It says right there, the Blue Cross Blue Shield covers for this. This is one of the insurances. But right now, after the pandemic, many insurances are covering for e-visits. Because it's easy, it's convenient. So can you imagine now in winter time, with snow, with rain, having to come leave your home, you are an elderly or you have a child, you have a job to do, you don't have time to do this. Well, you schedule your appointment at the time of convenience and you do it from home. Very convenient. So, okay, so any questions about this medical record, health record, personal medical records? Oh my God, it's a lot of stuff. But remember, at the end of the day, everything comes down to data that we collect from our patients for the benefit of the patient and, for the benefit of the organization, because we got to charge for those services. So financially, it helps the institution, medically speaking, is going to benefit the patient. Okay. Any questions? Okay, so
I
if
do
you
have a
don't,
question.
go ahead.
Yeah, so for people who are um diagnosed with like a full blown AIDS, for a representative that would be sitting at the front desk, are they able to access their chart with their information, or is the file like considered like classified specifically for that doctor's eyes only?
No, that's not classified. These are not those conditions that you're gonna say, oh, we have to hide this. Only certain people in the medical field can access this information. No, you can access that information. That's not a problem. What happens is that a patient who has the blue moon of AIDS will not visit the medical office. He's already hospitalized. This is a
Okay.
person who is um, in terminal illness. That's it, just waiting for the time for them to die. So usually they will not come. But when they have HIV or they have already